you very much. Assalamu alaikum, good afternoon again. I think we're running a little behind the schedule, so I thought that we have two papers, so I could take my time, but I think it appears that the lunchtime is fast approaching and everybody's hungry, so I would not be taking much time and will not take the liberty to take as much as I possibly could, so I'll be quick. So today I'll be talking about TEVAR. You know that thoracic endovascular aortic repair is one emerging technology that is entering the Bangladesh patient service area as well. It is very popular in the West and also in India and other countries of Asia. So it's time that we apprise our colleagues about these upcoming techniques and what we are doing about it. So my topic today will be thoracic endovascular aortic repair, beginning of a new era for vascular surgery in Bangladesh. Let me begin with a letter that I received from the daughter of the patient that we treated. This is a remarkable letter. We do hear from patients positive remarks, but this one particularly touched me because the patient being a moribund patient and her daughter living abroad, they're always tensed about the outcome of the procedures that is done on her. So they placed their confidence on us, and we delivered. And it's a testament of their happiness and their satisfaction. So this is what we work for as professionals. So if I read it, the bottom line is that they were extremely happy with the outcome that could be delivered for their patient. She had a difficult penetrating aortic also in the thoracic aorta. She was a woman of 65 years old having renal failure on dialysis, so not an easy situation to have. So after the outcome, they wrote these comments to us. We had a TEVAR working group formed for her, and I shared this particular comment to our TEVAR working group. The bottom line was that they were very happy with the outcome that we could deliver on this very difficult clinical scenario. And not to talk about this was also sent to me because, this is also something to be very proud of, to be very happy about. This was a vintage Armani watch. I don't see, this is my wrist is naked. I don't actually wear watches, but see, when I got this from as far as UK, it's really something to be very happy about. My son is very crazy about watches, so I just passed on the watch to my son. My youngest son is another enthusiastic collector of watches, so it really became an asset for the family, but I personally do not use watches. So this actually all came from that patient we took care of. The history, I already mentioned that the lady had sudden chest pain and crushing back pain, and when we investigated the patient, she had kind of consolidation in the left lower zone of the chest and mediastinal widening. We did CT angiogram that revealed a penetrating aortic ulcer. And I already mentioned that she was a lady of renal failure for which she was being dialyzed, hemodialyzed. So we planned thoracic endovascular aortic repair for this particular patient. This is the scenario. So the key hardware that we needed for this is actually the device was the Valiant Captiva coming from the Medtronic USA, and we need to actually import it from India. It's not, at that time the device was not readily available in our city, so we had to wait for a while, customize the device and ask for the device to arrive. Good news is that nowadays we probably have a stock of this kind of devices in Dhaka. So if we allow a couple of days, probably we can have the measurements customized and have the devices available faster than used to be in the past. The size that was measured for our patient was a 200 millimeter long device, 36 millimeter wide. We needed a super stiff Lunaquist wear, and the delivery had to be a 22 French on the device that was needed. You can see the device profile here, the Valiant Captiva. So the key steps that actually we needed for the planning was that we need to convince the party. They flew all the way from UK, the daughter of the patient, and we had to sit with them and talk for hours and convince them that we could do it. And good thing is that actually that daughter of the patient was my DMC junior. It was easy for me to probably convince her with our ability. We also were honest in telling them that the experience that we have is probably limited, but with the limited experience we have, we probably can pull it off. So they placed their confidence on us, so we could go ahead. We needed to have a team together, actually. It's not only for the vascular surgeons to do it. We needed radiologists with us, we needed anesthesiologists, we needed neurologists. In this particular case, we needed a nephrologist as well because she was on dialysis. So we need to prepare the patient like that, and we need to take preparations for possible neurological outcome like paraplegia, things like that. And it was a challenge that we get the device at hand in time. So this is the preparation we took for cord protection. We inserted a CSF drainage catheter on the back, and this photograph is blurred here actually. This is a graduate, like we could measure how much fluid we were draining, so we needed to maintain a CSF pressure of between 10 and 12 centimeter of water pressure. So we arranged all these things beforehand. Then we approached from the right femoral cord down. We took the angiogram of the approach vessels, and then we took the device directly without using a separate access sheath, because the sheath directly goes in, and we had to take it over a super steep lunocoist wear that's needed actually. Then we marked the precise proximal landing zone, and the rest was very easy. We did not need any post-dilatation because the lesion was sealed very nicely, and no post-dilatation was required. So these are the angiographic shots. You can see the, I think, this. Device is being delivered. You could see the penetrating aortic ulcer. The device is being delivered here, and on the right-hand side will be the completion shot. So you can see the lesion, the penetrating aortic ulcer, nicely excluded. This is how it looks like after the exclusion of the penetrating aortic ulcer. No endo leakage. We did not need any post-ballooning, and there was no landing site-related complications. This is the 1-year follow-up. Actually, the device sitting very nicely in the aorta, no residual leakage or no visibility of the penetrating aortic ulcer anymore. And one thing we are particularly worried about is the distal landing site-related complications. There can be fresh dissection at the landing sites. That was not there, actually, so it was very relieving for us to see this. A second case is recently done at NICVD. This is a very aged gentleman of 77 years of age. He had ISDDM and hypertension. He had very ominous looking sacral aneurysm sitting very close to the left subclavian artery. So we planned TEVAR, and this patient actually had, he was very high up in the society. He had all the options to go abroad, but he placed his confidence on us also. I forgot to mention that the previous case was done all by ourselves. We did not need any assistance from anybody from outside. For this patient, we invited a couple of guides from abroad, from India, and who helped us do this. This is how it was done. The same right femoral cord down, actually, we did a debranching. I mean, this is to exemplify our experience with debranching of the neck vessels. You can see the aneurysm and the device placed inside just before the delivery. In this scene angiogram, you can see that the device is already placed. The aneurysm has been excluded, and we can also see the debranched left subclavian and carotid artery bypass on the right-hand side. The next case will be an example of TEVAR being done for thoracic aortic aneurysm, where we protected the visceral branches. You can see the ominous looking large secular aneurysm of the descending thoracic aorta, and we put a wire separately to the celiac trunk, which is very close to the aneurysm. So we were afraid that the celiac trunk might be obliterated by the device itself, so we placed a wire to protect the celiac trunk. and it worked very well for us. I mean, without any sort of visceral artery occlusion, we could pull it off. So the 3 cases I showed you, we actually did more, but these probably highlight the basic experiences we have with the TEVAR procedures for thoracic aortic pathologies. So 3 basic indications for us actually: thoracic aortic aneurysms, thoracic aortic dissections, and penetrating aortic ulcers. So these are the 3 indications we are doing TEVAR in Bangladesh nowadays. We can call it a very lucrative option compared with open surgery. Just imagine if we could open the chest for the 3 cases I just showed. I think the mortality would be much higher. We haven't lost any patients so far, so I think this is a very positive experience that we have so far. Mortality and morbidity is much less with TEVAR compared with open surgery. The developed world has embraced this technology very, very enthusiastically, and even in India, the technology is being performed at some centers very routinely and in a large number of patients. I will discuss this, that the cost will be and still is a formidable challenge. So where we stand with TEVAR nowadays in Bangladesh, we are learning, of course we are learning, and in about 20 cases, that's my estimation, will be just on the other side, a few numbers, I'm not sure, but to my knowledge, it will be about 20 cases that we have done so far in about 7 years' time. The first case I remember we had done a case of EVAR, that was endovascular aneurysm repair for AAA. That was done at United Hospital. I was happy to be a part of that procedure in 2014, so far I can remember. So most cases were performed with assistance by overseas interventionists. That was something to begin with. Nowadays we can do it by ourselves, most of the cases. So our confidence is clearly building. So these are the centers that are offering TEVAR nowadays. These are the centers where the TEVAR has been performed already. In ICBD, I think we can say safely that most of the cases, and we have done the most number of cases at a single center, we can say that. Of course, at Ibn Sina, they are doing TEVAR as well. At Combined Military Hospital, they have done a few cases as well, and Bangladesh Specialist Hospital also have done that case I showed. So limitations for physicians is still a learning curve for all of us. We lack expertise in some sort of situations, like we are not experienced in dissection, because we have, to my knowledge, we have not done TEVAR in dissections, but that can be a very helpful procedure for dissections as well. We have not handled many complications. With EVAR, we have handled just one complication, I remember, because the contralateral limb was occluded, and we needed to do a FEM-FOM crossover the next morning. So that's the only experience that we have handling complications. That's very, very important to learn to handle complications. Otherwise, you are actually not learning the whole procedure completely. So confidence is building, like I said, but it's not 100% that is to be sure. For patients, cost is a formidable issue, because when you propose that this procedure is going to cost you 15 lakhs, 20 lakhs, it's not easy to convince these patients to commit to the procedure that we propose. So confidence from their side, are they placing their confidence on us? That's another issue, because we are confident, but it is important to let our confidence go across to the patient party, because that's when they will decide that, okay, these guys can do it. Like our sister, my patient, the patient I showed, I did not have to really talk much to them to persuade them to have the job done by our hands. But this may not happen in all the situations. So for them, it is also something that we need to keep in our mind, that it may be a challenge for the party as well to have their confidence on us as beginners. So decision making from their side can be a challenge sometimes. Are they going to accept our failures or complications easily? That's another thing that we should keep in mind. Before we actually finally decide to do it, we also need to be certain that, well, if we end up with failure, are they going to accept our failures or our complications easily or with an open mind and with support that we need? That's all from me today. Actually, in 48 hours' time, we're going to have this opened. Actually, this is a landmark in Bangladesh history, actually. It shows that as a nation, we can. I mean, our Honorable Prime Minister, she showed tremendous courage to have this built with our own finance. I mean, against all odds, we pull it off. So the point here is that if, as a nation, we can build a large bridge, a huge bridge across Padda, TEVAR is nothing. Thank you very much.